Good morning, everyone, and welcome to City and State's webinar, Closing the Medicaid Coverage Gap. I'm Ralph Ortega, and I'm the editor-in-chief at City and State. I'd like to first, before we start our program, thank our sponsors. I'd like to thank the Healthcare Education Project, 1199 SEIU, United Healthcare Workers East, and the Greater New York Hospital Association. And with that, it's my pleasure to introduce Ken Rasky, the president and CEO of the Greater New York Hospital Association, for some remarks.
Well, thank you very much, Ralph, and good morning to everybody. I want to thank you, Ralph, and City and State for providing the platform for this very interesting seminar that we have. My co-host is Millie Silva, the Secretary-Treasurer of 1199 SEIU, United Healthcare Workers East. Millie, I'm going to introduce you in just a few minutes to provide your remarks. But I wanted to say, Ralph, that the Healthcare Education Project, which is the sponsor of this, is an extraordinary entity in and of itself. It is probably one of the most prominent and certainly oldest labor management collaborations in the United States. And it has had its fingerprints and other characteristics all over a lot of important welfare programs and healthcare programs over the 30-year stretch that it's been involved in. Family Health Plus has been a major accomplishment. Child Health Plus, increasing enrollment and Child Health Plus has been one of the major contribution of the Healthcare Education Project. And a couple of years back, fighting against the attempts to repeal the Affordable Healthcare Act. And so it has this long tradition of trying to bring public education to very important healthcare issues. This morning, one of those issues is closing the Medicaid gap. And that issue, we have very much a distinguished panel that is going to provide some insights into that very important subject. But with that said, I'd like to turn it over to Millie. Millie, my co-host for this event. Millie from 1199, Secretary-Treasurer. Millie.
Thanks, Ken, and good morning, everyone. As Ken said, I'm proud to be the Secretary-Treasurer of 1199 SEIU, and it is a pleasure to be with you this morning amongst a stellar panel of experts to discuss the future of healthcare in New York. We're almost 3 years to the day when the first confirmed COVID case was diagnosed in our state on March 1st, 2020. Today is a time to reflect on what we've all experienced over the past 36 months and figure out, where do we go from here? Healthcare is forever changed, and the challenges of ensuring health equity across our communities and access to quality care for every New Yorker are more apparent than ever. As a state, we have a decision to make. Will we invest needed resources into Medicaid, which is the lifeline for millions of the most vulnerable New Yorkers, or will we allow health disparities to continue to grow, exacerbating our state's mental health crisis, jeopardizing elder care, and causing communities of color and low-income families to fall further and further behind? What I want to touch on this morning are the challenges that healthcare workers face every day trying to care for patients and residents as they continue to feel the effects of the pandemic and the lack of resources to attract and retain the healthcare workforce. Healthcare workers were struggling prior to the pandemic. In hospitals, nurses and others fought for years to improve staffing, while facilities struggled to recruit and retain technologists, mental health professionals, and other critical positions. In nursing homes, short staffing has been the #1 issue for workers for decades, and low wages and difficult jobs drive turnover rates that can exceed 70 to 80% in some facilities. Imagine having to replace the equivalent of your entire workforce every 15 months due to employee attrition. The pandemic turbocharged these challenges. When workers started getting sick in droves and felt as if they were being treated like cannon fodder when they weren't provided adequate PPE, many voted with their feet, deciding to leave the bedside for different work altogether. Nursing home workers found they could earn comparable wages in retail or other less stressful settings after their demands for adequate protection seemed to fall on deaf ears. The result is that those who remain in healthcare face crushing workloads that continue to drive out workers and prevent new ones from staying in the profession because they feel unable to provide the kind of compassionate quality care they know patients and residents need. My union 1199 represents workers of just about every healthcare title in every geography in New York. Every day I hear from workers as they share their stories of struggling to provide care. An LPN nursing home member from Western New York is working with less than half the staff complement they had before the pandemic. This means they're missing showers, they're served cold food, they don't get toileted when needed, and residents decline more rapidly than they should. An ER tech in New York City has seen the patient volume in the ER nearly double since the pandemic, including a spike in psychiatric patients. The workload is so crushing. She sees coworkers leaving mid-shift and staff even ending up as patients in the very ER that they work at due to overwhelming stress and exhaustion. A medical assistant in the pediatric surgery department at a children's hospital in Buffalo has seen the time it takes to move through the steps for typical surgery go from 3 to 5 days to 5 to 10 days. As a parent, can you imagine having to delay essential medical care for your child because there aren't enough staff? There's a mental health care worker in Queens who described a crisis in his institution because they simply cannot recruit or retain staff to work with clients with developmental disabilities. The wages are too low, but his employer cannot afford the raises that are needed to retain that workforce due to insufficient Medicaid reimbursement rates. To meet this crisis head on, everyone, New York has to close the Medicaid gap that has widened after 15 years of flat funding. The failure to fully fund the healthcare system means safety net hospitals are on the brink of insolvency, and institutions which are trying to do the right thing and recruit and retain staff with higher wages and benefits are putting themselves at risk of bankruptcy. Listen, the governor's proposed budget fails to recognize the crisis, and it's actually a net decrease for hospital funding, including failing to renew last year's $700 million in safety net funding. The governor's pledge to meet the crisis in mental health is largely capital spending and does nothing to address the crisis in mental health care worker staffing. Our union and our healthcare provider partners are demanding a 20% increase for nursing homes, a 10% increase for hospitals, and additional funding for safety net institutions. This is the funding that the healthcare industry needs as we work to rebuild the healthcare workforce that all New Yorkers need and deserve. And so I'm greatly encouraged to be here this morning with all of you as we prepare to hear from the panel about why it is so critical at this moment in time to close the Medicaid gap. Thank you.
Thank you. Thank you.
Great. Do you want anything more you'd like to say before we start?
Absolutely not. David,
Okay, great.
please.
Good morning, everyone. My name is David Rich. I'm an Executive Vice President for Government Affairs here at Greater New York Hospital Association, and we're so glad that so many people have joined us today. We'd like to get started because you all tuned in to hear from our experts who are going to be speaking to us today about the Medicaid coverage gap. Our first speaker is Dr. Jamila Michener. She's an associate professor and co-director of the Cornell Center for Health Policy. Her research focuses on poverty, racial inequality, and public policy in the United States. Her recent book, Fragmented Democracy, Medicaid, Federalism, and Unequal Politics, examines how Medicaid, the nation's public health insurance program for people with low income, affects democratic citizenship. And look for her book tour sometime near you. Her research has been supported by the Woodrow Wilson Foundation, the Russell Sage Foundation, National Science Foundation, and many other foundations. She received her MA and PhD from the University of Chicago. And prior to working at Cornell, she was a Robert Wood Johnson Health Policy Scholar at the University of Michigan. So with that, I'd like to turn it over to you, Dr. Michener, for your presentation.
Thank you so much, David, for that introduction. I'm going to share my screen, and I want to apologize that I am obviously zooming in here from my car. It took some effort to get myself to a place where I had great reception and where you all would be able to actually hear me. So that meant getting in my car and driving somewhere other than where I was. And those are the travails of living in upstate New York. In any case, I want to take this few minutes that I have and take the opportunity just to perhaps set the stage for the conversation that we'll have and think a little bit broadly and then also specifically about Medicaid in the context of health equity and what the challenges and possibilities that face Medicaid, and specifically even thinking about this in the context of New York State, thinking about the kinds of gaps and the kinds of, honestly, chasms in resources and care that are created by an inequitably funded system like the one we have now with Medicaid, both nationally and in terms of New York State. So somebody asked in the chat whether I will share the slides. The answer is yes. I apologize for not getting a chance to do that in advance for all of you, but absolutely. So let's just jump right in. First, the conversation and the focus on equity is one that at this point, it may not be, or certainly will not be always, and certainly will not be forever, but one that at this point is shared from the top down, right? So Shakita Brooks-LaShore at the Center for Medicaid and Medicare Services says, look, we should be looking at everything through the lens of health equity. We should be thinking about all of the decisions that we're making with respect to Medicaid through the lens of health equity. And of course, there's a big distance between saying this and actually implementing the policy changes that are necessary to get there. And it's worth thinking about it. And I'll spend a few minutes talking about what those policy changes look like, right? What it means to get to a point where we're really looking at Medicaid through the lens of equity and being honest about what's lacking and thinking about the political configurations, the kind of power and the resources that it's going to take to get to where we want and need to be. So just a little bit on the kind of some history here and the history of US healthcare. And I'm not going to spend too long here, but I think it's a subtext that's worth pointing out. So for most of US history, the federal government actually had very little involvement in the provision of healthcare. State governments from very early on, even when what we know of now as states were some ragtag colonies, always had to deal with and had primary responsibility for dealing with the provision of healthcare. And a lot of the onus was put on local governments. But if we think about the sort of long history of the US, the federal government is a pretty kind of recent player when it comes to being a major player. So when we think about Medicare and Medicaid, these are programs that emerged in the 1960s. In the broader history of the US, for much of the time before that, the federal government was actually doing very little relative to states and localities. Now we're at a point where healthcare is really an intergovernmental affair, but states are still really critical and make a lot of major decisions. And so to say what's happening in New York State and to focus on holding New York State accountable is very much in line with the kind of the longstanding structure of our healthcare system. One thing I want to point out, and I'll return to this as I move forward over the next few minutes, is that there have always been, this is part and parcel of, built into the very foundation of the US healthcare system, mechanisms for the systematic exclusion of marginal groups in the US healthcare system, whether that's indigenous people, folks who were enslaved, indentured servants in the very early part of our history. There has always been consistent discrimination against recent residents, migrants, and immigrants, and against certain categories of types of workers, right? So who has had access to the benefits of our healthcare system at whatever state it's been in at various points in history has always been differential, and there's always been systematic exclusion. who's excluded and how they're excluded, what the mechanisms of exclusion are, have changed over time, but the fact of exclusion has remained consistent. And we'll talk a little bit about some of the mechanisms of exclusion that we see today, and specifically about Medicaid reimbursement rates as a crucial mechanism. But Medicaid was a policy that was designed from the start to be very targeted, right? It's means tested. It's only for folks who are low income. It's not a universal program, imagined in the same way as Medicare, for example. It was designed to be intergovernmental. I've already mentioned this. And the idea there was states were going to have lots of flexibility. And this meant lots of variability, that what you were going to get was going to be really different depending on where you are. And essentially, this amounts to rationed care. It's not that everybody can get what they need based on their needs. It really is contingent on a lot of things, on your state government, sometimes on your local government, and on your life circumstances, which ebb and flow over time. And one thing to keep in mind as we think about this broader design and structure of Medicaid is that it's not how it had to be, right? We, of course, have the immediate comparison of the counterpart of Medicare, which even today is very different than Medicaid. And I'll talk about some of the ways. One, for example, is that Medicare has higher reimbursement rates, still not as high as private insurance, but significantly higher. So we created, at the same time that we created Medicaid, we created Medicare. And Medicaid was called the friendless stepchild of Medicare, right? Medicare had all the political wherewithal. It was what the entire debate during that particular political moment was about. And in fact, there wasn't one legislator in that Congress, I think it was the 83rd Congress, there wasn't one legislator that had supported Medicare that got voted out of office on that, during that election season when Lyndon Johnson was running for president in '64. And so it was a really clear mandate, and the mandate was around Medicare, which was a universal program and a program that had a lot more support, a lot more resources. But Medicaid was always thought of as this kind of side thing, and was always underfunded and undersupported and underpowered politically relative to Medicare. Nonetheless, despite being the friendless stepchild, despite initial claims that Medicaid was going to be a small addition and wasn't going to be a major pull on federal or state resources, this program has grown stupendously over time. If we just look at Medicaid enrollment between 1966 and 2021, this is absolutely incredible. And it's now one of the most significant federal and state expenditures and an absolute pillar of our healthcare system. And part of this is just the depth of need that Medicaid is addressing and reflecting. This idea that, oh, this was going to be a small program really wasn't reflective of and attuned to that depth of need. And these numbers are even higher in 2023. They continue to climb. And Medicaid, despite its flaws, despite that it's always been under-resourced and underpowered relative to Medicare and relative to what it really should be, to what a system that provides resources and care for all on an equitable basis should look like. Despite these weaknesses, Medicaid is a pillar of our US social policy. And I always think it's important to say that if we're going to be talking in a way that's sort of critical and thinking about how to improve Medicaid, I think an important backdrop is to realize how much Medicaid is doing. The research record shows that Medicaid saves lives, that when we expand Medicaid, when more people have access to it, they live longer and healthier lives. There's at this point very little to suggest otherwise. It improves children's health, and this is if we follow children over the life course, children whose mothers got Medicaid through expansions, for example, that were made in the 80s, and we follow these kids over the life course, and we compare them to a cohort of similar kids who just fell short of qualifying for those expansions, and we see that their long-term health is improved, their educational outcomes are improved, long-term financial outcomes, why my phone is ringing, long-term financial outcomes, reduced rates of recidivism. So when we give formerly incarcerated people access to Medicaid, they're less likely to recidivate. It reduces the likelihood of eviction. And of all programs, this is probably now, this study was before we had the expanded child tax credit. But separate from that, when we think about traditional means-tested programs like TANF or SNAP or what have you, Medicaid by far has the largest effect on child poverty relative to those other programs. So Medicaid is doing so much, even with relatively little in terms of the scale of resources that we would really need to invest to see sort of full and equitable access. And one thing that's important to keep in mind is that Medicaid has really important implications for racial equity. So this just shows the proportion of Medicaid beneficiaries in a given state that are people of color, Black, Latinx, Indigenous, and so forth. And we can see that in half of these really dark maroon colored states, we have about 50% or more Medicaid beneficiaries who are people of color. And in another huge chunk of the darker pink, we have between 30 and 49%. There are only about 8 states left that have fewer than 30% of Medicaid beneficiaries who are people of color. So when you're making policy around Medicaid, we're thinking about how to fund that program. It also has implications for racial equity in a really direct way. And we saw this with the expansion. When we expanded Medicaid, we can look at who benefits in terms of the insurance rate, in terms of avoiding medical debt, and disproportionately, everyone's benefiting. I think that's really worth noting, right? Everyone's uninsured rate is going down. Everyone's medical debt is going down. But Black and Latinx folks benefit more, in part because those needs were so much greater. And of course, Medicaid has implications for economic equity. Evictions fall sharply in the wake of Medicaid expansion, and fewer low-income adults have unpaid medical bills. So if we know this, if we know the benefits of Medicaid, if we know that for every dollar we invest in this program, we're getting such a greater return in terms of what's happening in people's lives and for their well-being. And of course, New York State has a really substantial Medicaid program, one of the largest in the country. And that has, of course, expanded over the last 10 years in the wake of Medicaid expansion. And that we've seen the effects of that. The uninsured rate has gone down, enrollment has gone up. So the question is, where are we now and where do things need to go? And one thing I want to focus on when we think about that, as I sort of round out in these last few minutes here, is to think about New York's Medicaid investment relative to similar states that have high population. So what this graph shows us is the top 10 most populated states in the country, right? And where they rank in terms of their state reimbursement rates, right? If we can look at which states are reimbursing what, and we can rank the states in terms of how generous their reimbursement is. And what we see is that New York, which is a few down right under Florida, because these are rank ordered in terms of population size. And so New York is the 4th most populous state, and it's ranked 51st in terms of its reimbursement ranking, right? And this is really substantial because New York has a huge population. A substantial portion of that population is people of color.
I need that.
They have a really significant Medicaid enrollment. And many of New York, 64% of New York State's Medicaid enrollees, Medicaid beneficiaries, are Black, Latinx, or other people of color. And so for Medicaid to be ranked last in terms of its state Medicaid reimbursement in New York is striking. And to be fair to New York, I do a lot of research around Medicaid, and I do a lot of comparisons across states. That's a lot of what my work focuses on. And in many ways, New York is a relatively generous state when it comes to the benefits that people receive, right? But because it's not generous when it comes to reimbursement, there are many other ripple effects, right? And we heard some of this earlier, which is the ripple effects, for example, they carry over to healthcare institutions and to not just to providers, but for the folks that are working in those institutions and keeping them running, right? This low rate of reimbursement means that healthcare institutions do not have the resources that they need to ensure that they can have the workforce that they need, and that workforce can have the benefits and the resources that it needs to actually be a robust and equitably cared for, not just in terms of health, but also in terms of economic equity workforce. So this is a huge problem. And even though there are areas where New York State is doing reasonably well relative to other states, this is an area where New York State is doing especially badly. And it's a linchpin of so much of the kind of funding stream and ecosystem and infrastructure for Medicaid. Now, of course, there's lots under the hood here. There's a lot of variation. So if you look at, for example, New York State's reimbursement of child dental services. And we can compare this to the top comparator, the folks who tend to reimburse the most, private insurance. And New York State is actually not doing badly. It's reimbursing 80% or more of this kind of care. And that's often the case for care that's oriented around certain populations, sympathetic populations like children. But then when we look at other kinds of reimbursement, for example, and this is with Medicare as the comparator, and we look at the ratio of kind of the Medicaid rates and the Medicare rates in an area like obstetrics, New York State is actually in one of the lower categories. That light blue is the second to last category relative to other states. And New York State is not very different, for example, from places that we might think that we're very different from North Carolina, from Texas, and so on and so forth. And many of the places that we might imagine ourselves to be more progressive relative to, or more generous relatively to like Florida or what have you, are actually doing more on this score. And when we think across the board, when we think broadly about that ratio of Medicaid to Medicare, and the reimbursement fees that states are paying, New York is actually in the kind of lowest tier on a general level. So there might be some populations that it reimburses well for, like children, some that it really is not doing a great job with, like women and birthing people. But overall, New York State is really a laggard in this area. And again, that has effects that go pretty deeply into structuring our health system. So I want to end here just by saying two things. One is that this really matters for people's access to doctors and to care, right? What we see in this graph is that as the payment rates increase, the reported change in, or patients' reported changes in their ability to see a provider also increase. So patients are more likely to report that their Medicaid beneficiaries are more likely to report that they're able to see a provider as the Medicaid reimbursement rates go up. Why? Because providers can afford to be present, to have the staff they need, to have the infrastructure they need to actually enable people to access care. And the other thing, and this is what I'll end in, that I just want to emphasize, is that the people who are experiencing these benefits and these services, they also feel the implications, the ramifications of the lack of funding and the gaps in care and in the healthcare infrastructure that is produced by, for example, these low reimbursement rates, right? So this is a woman, I interview lots of Medicaid beneficiaries and increasingly staff that work in hospitals and other kinds of providers, especially working folks. I have a big project going on now where I'm talking to these folks directly about their experiences. And one woman, hundreds of them across the country. And this is just one example. Many people say things like this to me. We may think that Medicaid reimbursement rates are like a policy wonkish issue that ordinary people don't understand, that regular beneficiaries or working people can't grasp, but they absolutely can, and they reflect that in their experiences. This woman talks about how it's hard to access dental providers. There was only one in their county that accepted Medicaid. And so now if you want dental care, you have to go out of the county, which means what? Time off work for a working person who's relying on that income, who's working hourly or what have you. That's a major downside and a major barrier to care, right? And so she goes on about how this is, even for children, it's the case, and how this really is a problem, it's a barrier. And at the very end of this statement, she says something has to be done there. And if it's depending on what they pay, what they cover, then that needs to be looked into. I'm going to emphasize here, ordinary people completely pick up on this. Silent somehow keeps ringing. Completely pick up on this and understand that there's a structure to the system, who's getting paid for what and how, that there are inequities there that translate into their experiences. And of course, I'll end here with saying a lot of this is a function of power. Who has power to push, to influence the policy processes in ways that mean that you can't continue to overlook the substantial subsets of people who are not benefiting from the status quo. And power is a social determinant of health. We can't have health equity, we can't have a healthy New York State, and we can't have a healthy country if we don't ensure that the folks who are most affected by these kinds of policies are able to have their voices heard and influence the decisions being made by the folks who are determining what budgets look like and so forth. So I will stop there. I know that was a lot.
No, that was terrific. Thank you so much, Dr. Mitchner. It was extremely enlightening. You know,
Absolutely.
we tend to think we know a lot, but you really taught us a lot today. Just if you don't mind, just a couple questions before you go and before the snow makes you leave us. You mentioned, and I think you really hit the nail on the head here, that on the one hand, New York has a very, what people would view as a generous program because it has so many different types of benefits, it's taken so many different options. But what it feels like is they promise a lot, but then they don't pay for it. And so I'm wondering if that's what you've been observing. I mean, we have, what our economics team has learned is that they're covering about 61% of the cost of care in hospitals. And even less when it comes to mental health care and behavioral health. So, I mean, is that what you've been finding as well?
Absolutely. And this emerges in lots of different ways. So when I first started studying Medicaid, I mean, now we're talking almost 15 years ago, it's been a long time. I remember I grew up in New York, I'm from Queens, I work at Cornell now, but I've sort of long time New Yorker. And I remember starting to look at state data in terms of like what kinds of benefits different states offered and what kinds of, Medicaid, benefits people could have access to. And I remember looking at all of the New York State, paying a special attention to the New York State benefits and thinking, oh, my state is doing well, And then I started to do this research on the ground, talking to beneficiaries, talking to providers, and really looking at what was happening internally in the systems. And what I was really surprised to find people recounting significant negative experiences with Medicaid and as Medicaid beneficiaries in hospital systems. And it took me a while to figure out that this was the linchpin, that on the books, you have access to all sorts of benefits in New York State that you just don't have, even on the books in Kentucky, in Mississippi, in Georgia, and so forth, right? Our Medicaid transportation benefit is pretty robust, and so on and so forth, on the books. But when you actually talk to people, it's a very different story, right? And the transportation benefit is a perfect example of that. Every New Yorker who's on Medicaid should be able to have access to transportation to their medical appointments if they need them. Behavioral health is another. New Yorkers ought to be able to have access to mental health programs and practitioners if they need them. All of these things are on the books. But if you talk to people who are trying to access those services, they can barely access. And when they do, they experience sub-tier, what they understand to be sub-tier services. The number of New Yorkers who said, I used to have private insurance, and it's really different than this. This is a much lower level of insurance. And so there's a trade-off, not necessarily a trade-off. Actually, it's not a trade-off. But by giving a lot of people access and by giving access to a wide range of benefits, without funding enough to make sure that access actually translates into people getting what they're promised, we've created a system and a structure where this is exactly what we do. We make promises as a state and we don't deliver. And it's a choice, right? It doesn't have to be that way. We can invest more in healthcare systems and in people. Ultimately, investing in a program like Medicaid and in healthcare systems is investing in people, the people who rely on those systems, the workers who populate those systems. It's not just kind of contributing to more healthcare costs or bloat, right? And so it's important to frame it properly as an investment in people that is reflective of people's needs and their preferences and their wants.
Absolutely, absolutely. And you put it perfectly by saying it's a choice. And we're trying to make the point in Albany this year that they should make a different choice, which is to actually fund the program. So thank you so much. Based on what I've seen from the chat, you're getting rave reviews and you've really taught us a lot today. We want you to be safe up there in snowy Ithaca. So we will let you go now, but thank you so much again. And as was pointed out, the slides will be shared with everybody who participated in the Zoom at the end of the program. So thank you so much.
Thank you, everybody. I'm so grateful for the work you're all doing. So have a great day.
Thank you, you too.
Bye.
So now we'll turn to our next speaker. Our next speaker is Dr. David Grabowski. There he is. And he is a professor of healthcare policy in the Department of Healthcare Policy at Harvard Medical School. His research examines the economics of aging with a particular interest in the areas of long-term care and post-acute care. He's published over 200 peer-reviewed articles, and his work has appeared in leading peer-reviewed journals all over the country. His research has been supported by the National Institute on Aging, the Agency for Healthcare Research and Quality, the Centers for Medicare and Medicaid Services, and also a who's who of private foundations. He's also a member of the Medicare Payment Advisory Commission, MedPAC, which, as many of you know, is the independent agency established to advise the Congress on issues affecting the Medicare program. Dr. Grabowski received his PhD in public policy from the Harris School of Public Policy at the University of Chicago. So our first two speakers are both alumni of the University of Chicago. And Dr. Grabowski, thank you so much for being with us today. And I'll turn it over to you.
Great. Thank you so much, David. And good morning, everyone. It's great to join you today. I'm going to go ahead and share my screen here. And there we go. So I'm super excited to be here. Dr. Michener gave us a great overview of a lot of the challenges with Medicaid. I want to do a deep dive on one particular part of the program, and that's Medicaid payment of nursing home services. As David just mentioned, that's where I've focused a large share of my research over the years. And I've had several different angles, both research and policy, into this sector as a member of MedPAC. So very excited to share some thoughts on the adequacy of Medicaid nursing home payment. I want to start just with a level set, and that's this really falls nicely out of Dr. Michener's presentation. She mentioned kind of Medicaid and some of the fragmentation in our system, and nursing homes are certainly representative of that fragmentation. Nursing homes have two very different types of residents or patients. On the one side, they care for long stay residents who will typically spend the rest of their lives in the facility. That's largely paid for by the Medicaid program, with some private payment, although private payment in most states, including New York, has declined over the last couple of decades. On the other side, nursing homes do what's called skilled nursing facility care. That's care following an acute hospitalization. And at least historically, in traditional Medicare, that required a 3-day hospital stay. More and more that care is being covered by Medicare Advantage, but at least historically, most patients were covered by traditional fee-for-service Medicare. So two very different payers. My students often ask me, why do we have this setup where Medicare covers all of healthcare for older adults and Medicaid covers their nursing home services and their other long-term care? And my response is always, you'd never design a system like this if you were starting from scratch. And I think Dr. Michener kind of hammered that home during her presentation. So thinking about these two very different payers, predominantly Medicare on the short stay side, Medicaid on the long stay side, Medicare is a very generous payer of nursing home services. And these are data from MedPAC going back to 2000. You can see in every one of those years, this is just the Medicare part of the kind of cost reports. Medicare is associated with a double-digit margin, meaning Medicare is a very profitable payer relative to costs. It's in every year been above 10%. We can contrast that, however, with the rest of sort of their mix of residents. So here I've shown you, these are also MedPAC data starting in 2017. You can see what's called the all payer. So that's across every payer. What is their overall kind of margin, operating margin there? And you can see in 2017, it was quite thin, actually negative in 2018. 2019, once again, quite thin. And then I'll come back to this point. Why has it gone up, at least during the early part of the pandemic? The other point I want you to take from this slide is if Medicare is such a generous payer, what's kind of weighing down these margins? It's Medicaid. Medicaid accounts for the vast majority of bed days in a facility. So Medicare is a very generous payer, the double-digit margins, but it's a very small share of the total number of residents. And you can see this in New York State on the Medicaid side. These are data from our sister agency. So I'm a member of MedPAC. MacPAC is the Medicaid and CHIP payment advisory commission. And they just released a report in January looking at Medicaid payments in nursing homes relative to acuity adjusted costs. And I'll say a couple of points. First, on average across the entire country, they estimated Medicaid pays about 84% of acuity adjusted costs. New York State, and you can see that right there, is paying 76. So New York, as Dr. Michener noted, is below the national average. So that's concerning. Some states are doing quite well. We have states out there like Delaware and Oregon that pay above costs, and then we have states that are doing worse than New York, South Dakota, for example, that's quite even less generous. But New York ranks towards the less generous end of the distribution. What does this look like if we were to split this out? So this is just kind of breaking out by facility, what share of facilities in New York State are paying kind of above costs. And you can see it's a very small share there on the right. It is a sort of a bell-shaped distribution here. And the modal facility in New York State is getting about 80 to 89% of the allowed amount of costs. Very few, less than 8%, are getting paid, above costs. You can see there's even a few on the left that are below 70% and even less than 60%. So New York is certainly, according to the MacPAC data, not reimbursing nursing homes anywhere close to their costs. I was one of the outside advisors for the MacPAC report, so I do want to highlight some issues or limitations. First and foremost, Medicare cost report data are noisy. We know that when we look at data at MedPAC, there's certainly issues there. I think I've highlighted that middle point because I think it's a really important one. I know there's been issues in New York State and elsewhere, but these data can't account for what we call related party transactions and other practices by nursing homes, which may artificially inflate reported costs. And so in addition to kind of reforming Medicaid, we know we need greater transparency and accountability as to how providers are spending dollars. And then finally, these are just base payments. These don't include supplemental payments to facilities. But all of that said, I think the MacPAC report is very important in suggesting New York is not a generous payer of nursing home services. So thinking about New York directly then and how we begin to address kind of adequacy of Medicaid payment, New York has two policies, which I know this group is well aware of, to sort of put up some guardrails about how facilities spend money, public dollars. One is minimum staffing standard. The other is this minimum direct care spending threshold that facilities have to spend a minimum amount on staffing and direct care. We just released a paper last month. It wasn't on New York in particular. It was using national data. But we want to make this point that both of these policies are really important. You don't want to just implement a minimum spending threshold. You don't just want to do a minimum staffing threshold. And there may be other policies that New York State wants to think about, and I'll address those in just a moment. But we made a very simple point in this paper we published just this month that facilities with a higher share of Medicaid residents tend to spend a larger share of their revenue. They just have less, the denominator smaller. They have less kind of dollars coming in. And so it's, even though they have, and you can see that on the bottom there with the facilities with a high payer mix, their nursing staff expenditure ratios, the dollars going to direct care, are higher, even though they staff below other facilities. And so for New York State, this is going to be a challenge. How do you ensure adequate staffing and spending? Both are important policies, but that may be necessary, but not sufficient. I do want to talk about the economics of nursing homes following the pandemic. And it's really, nursing homes had some challenges pre-pandemic, but I think post-pandemic, we've seen a tremendous shift in terms of what's happening on the ground. SNF occupancy is way down. These are MedPAC data. You can see prior to the pandemic in 2018, 2019, occupancy was about 85%. It's hovered around 75% since then. And this isn't, across the board. Some of the most lucrative patients, those coming from the hospital, are way down. And these are data just at the beginning of the pandemic. But you can see it was a real shift in terms of hospital discharges to nursing homes. And a lot of patients were going to home health rather than to skilled nursing facilities. The workforce, and this comes up a lot. Millie mentioned this in her introductory remarks, just some of the challenges with the workforce. We saw a dramatic shift in workers at the beginning of the pandemic. We lost nationally over 400,000 workers. It's been back up, over the kind of last year or so, but there's a long way to go. Many people have asked sort of, well, given occupancy is down and staffing is down, are they sort of roughly equal? And I think a couple of things to push back on with that. There are a lot of vacancies. There are a lot of staffing shortages, and I would assert that the residents living in nursing homes today need a lot more services than those pre-pandemic. We're seeing a real increase in acuity. So we certainly need to attract and retain more workers. This is kind of the elephant in the room for the nursing home sector going forward. How do we get more dollars into the system, and how do we get those dollars to workers? Interestingly, nursing homes experienced the largest wage growth during the pandemic, but they also lost the most workers. And so it suggests it's going to take more payment, more kind of dollars for wages, but it's also going to take a lot more than that. It's probably going to take better working conditions and benefits, and kind of a real shift in sort of how we think about the workforce in this area. I did mention that, and I touched on, I just wanted to show this figure again. How are sort of things getting better, at least in the early part of the pandemic? I get this question a lot from folks at MedPAC. It turns out, if you look at some of the broad data, we haven't seen a lot of closures nationally. I know some rural markets, maybe even in New York, have experienced closures, but we haven't seen widespread closures yet. You can see just the number of nursing homes certified as taking Medicaid. It's declined some, but not the bottom has yet to sort of drop out. Another marker we use at MedPAC is just the number of publicly announced deals or transactions. There's still capital sort of flowing into this sector. This hasn't kind of dried up yet. So at least along some big economic indicators, I'm just going to go back once again. All payer margins look much stronger than they did pre-pandemic. Not a lot of closures, and transactions still seem to be ongoing. What gives here? And so I would say nursing homes have benefited from a series of kind of one-time policies during the pandemic. We all know about the COVID relief funds, and that was a big number. The PPP dollars that flowed into nursing homes, many of which were in loans, but at least half of which were forgiven. And then finally, the one that we've been examining in some of our research is the public health emergency. That waiver that nursing homes had to have a 3-day hospital stay in order to admit a new Medicare patient under the traditional skilled nursing facility benefit. It turns out, I showed you some data earlier, that new admissions really declined, But in red there is just the number of SNF episodes. These are data that we're have forthcoming at a journal over the next couple of months. But you can see there was a huge spike in SNF episodes, and what sort of sustained that was this waiver of the 3-day hospital stay, this ability to skill in place. And there's a lot going on in this chart, so I apologize, but I want you to focus on the top panel are just the long stayers. So individuals who in green there were able to use the 3-day waiver. They didn't have to go down the street to the hospital. They were able to just convert over from Medicaid to Medicare status. Many of them, as you can see in green there, that huge spike in the middle panel, panel B there on the top, they actually had COVID. So nursing homes seem to have used the 3-day waiver under the PHE to really direct services to individuals with COVID on site. We estimate this was associated with lots of additional resources for nursing homes that could help cross-subsidize the care of Medicaid long stayers throughout the building. Well, guess what? That the public health emergency is going to end pretty soon. And so what I would argue is, like, when you put all of this together, New York's not a very generous payer of services. We're seeing fewer individuals wanting to live or work at nursing homes in New York State and nationally relative to the pandemic. A lot of the dollars that I think have kept nursing homes strong financially during the pandemic are about to shift. And we know the relief funds and the PPP are long over. The PHE waiver is now scheduled to end in May of this year. We're really at this crossroads, and I think New York has some good policies in place, like the staffing standard. I know the federal government is also thinking about a staffing standard. You do have this requirement that nursing homes have to put a fixed share into direct care. The final piece of this is how Medicaid pays nursing homes, and I think in New York State and elsewhere, facilities have really relied on this cross-subsidization. David, in turning it back to you, I think those days are very much numbered, and I think New York, like other states, is really going to have a moment of reckoning. Thanks.
Thank you so much, Dr. Grabowski. Extremely enlightening, terrific data. One of the themes that you touched on was the need for cross-subsidization, and that's a theme that we find on the hospital side, where hospitals need to figure out if they can charge private insurers more. On the nursing home side, they don't have as much private pay, and so they have to hope Medicare will continue to pay more. But as you said, at some point in time, I think this is what you were meaning, the federal government's going to start perhaps cutting back on Medicare payments, not just to nursing homes, but to others as well. I mean, how does MedPAC look at the cross-subsidization issue? I mean, they're responsible for advising on Medicare policy, obviously, but what would you say is the view there about, why states are allowed to get away with this in a way?
Sure. So just I'm speaking for myself right now, but I can give you some insight. Medicare, by its charter, MedPAC by its charter is mandated to really advise on Medicare policy, and so it's hard to look with blinders at just Medicare and ignore. You David gave the perfect case. We'll have a discussion of hospital payment updates on the hospital side. Commercial is cross-subsidizing Medicare. Then kind of later that morning or that afternoon, we're having this discussion where Medicare is cross-subsidizing Medicaid, and Medicare is the favored payer. And we just have to live with this fact that Medicare is lives in kind of a multi-payer world. And sometimes you're going to be the favored payer, and sometimes you're going to be the less favored payer. But I think in both of those instances, there has to be some thought about the safety net, and whether it's through aggregate policy or through kind of other policies, how do we ensure that all of our beneficiaries, because every one of the individuals, at least on the nursing home side, all of these individuals, for the most part, are dually eligible. meaning like even though Medicare is paying for their short stay, they're also Medicaid and vice versa. You know, the Medicaid residents, the long stayers, when they go to the hospital, they're on Medicare. And so the idea that they're kind of separate from Medicare is just incorrect. And so how do you come up with policies that encompass both kind of Medicare and Medicaid? And I think to finally, David, you touched on this. Medicare, I think, has really declined in terms of new admissions coming from the hospital to nursing homes. And so that cross-subsidization, I think, is going to be threatened over the next several years, where state Medicaid programs are really going to have to step up, because they've been able to benefit for a lot of years from kind of Medicare. My sense of that market, and one is just fewer traditional Medicare beneficiaries wanting to go to nursing homes, and then the other part is Medicare Advantage, which we haven't touched on, but which is not as generous a payer. I don't have to tell that probably to this audience, but folks in nursing homes are not excited about growing Medicare Advantage shares.
Yeah, no, absolutely. And what we have found is we've found that hospitals have had more difficulty discharging to nursing homes because of the fact that the staffing issues, you know, they just don't, the nursing homes don't feel like they have enough staff to accept as many residents as they did before. That may have something to do with the census reductions that you pointed out earlier. But it, you know, as we said before, you know, long-term care is one of those situations where New York State has promised a lot and has grown a lot of programs in the long-term care arena, from all of which are good, from home care, from consumer-directed care, from all of those things are, you know, popular and people like them. But again, they sort of expand programs without necessarily paying for the ones that they already have. So that's always been a struggle. Is there anything else you'd like to comment on before we move on?
I'll just say that quickly, that's I think sort of fits with the national perspective of New York. Lots of innovative programs. Oftentimes you'll see a lot of this written up in academic journals, yet then when you look at data like I put up today in terms of generosity of payment in nursing homes, which is kind of one of the core services here, New York surprisingly ranks below. And I think as Dr. Michener said earlier, I think New York, if like you ask most New Yorkers, where do we sort of fall out, and who are our sort of the other states that sort of pay nursing facilities similar to us? I don't think they'd guess the company they're keeping there, that they don't sort of look a lot like some of the peer states. So I'll leave it at that. But thank you, David.
No, that's true. I can say this, you can't, but it's kind of a rogues gallery.
There you go.
But thank you so much, Dr. Grabowski. We so appreciate your expertise and sharing it with us today. And again, we'll make sure that your slides are shared with all of the participants. And I hope you have a good rest of your day.
Thank you, everyone.
Thanks so much. So now we are going to move on to a discussion of behavioral health and mental health and the impact of Medicaid underpayment on both. We have a terrific couple of people to help us understand better what's going on in the mental health system. First of all, we're going to hear from Dr. Sabina Lim, who we have the pleasure of having with us here in studio, if you will. Dr. Lim is an MD, MPH. She's the System Vice President for Behavioral Health Safety and Quality and the System Medical Director at the Mount Sinai Health System. Dr. Lim graduated from the University of Michigan, received her MD from SUNY Buffalo, and her MPH from Columbia University Mailman School of Public Health. She completed her psychiatry residency training at Yale University and had a number of positions at Yale before she joined Mount Sinai in 2013. She's also on a lot of different advisory boards. She currently is an appointed member of the New York State Public Health and Health Planning Council and of the New York State Behavioral Health Services Advisory Council. And then after we hear from Dr. Lim, and I have a little bit of a Q&A with her, we will be hearing from Mr. Lamont Williams, who is a certified peer specialist and program manager at the New York City Health and Hospitals Peer Academy. I'll talk a little bit more about him after Dr. Lim's presentation, and she's done. and we'll have a great conversation with Mr. Williams at that point in time. So now let me turn it over to Dr. Lim.
Thank you, David. And good morning and thanks everyone. It's great to be here and very grateful to City and State and Greater New York and 1199 and all the sponsors, because this particular topic and behavioral health is it's not something we talk about very much. And I think it's really important that this gets out there. And I'm really grateful to the panelists before me, because I think what you will hear is that there are recurrent themes and points. And I think it will be highlighted in how those kinds of things are showing up in the behavioral health arena. So I promise this is the most wordy slide out of all of the slides, but everybody is talking about, quote, mental health, mental illness, substance use every day, right? And so part of that talk is, so how do we value? How do we show our value in that how we care for people with mental illness and substance use disorders? And part of showing value is, of course, showing monetary value, right? And as everyone has noted, there has been an under reimbursement of behavioral health care. And by behavioral health, I mean both mental illness and substance use disorders. This is a long-standing issue. This is not a pandemic issue. This has been going on for decades, basically. So just to give examples of the degree of underpayment, Greater New York did an analysis a couple of years ago, and David, I think, referenced even newer data. At that time in 2019, Medicaid covered only 64% of inpatient psychiatric hospitalization costs. It got worse after that. New York State hospital-based mental health clinics did not have a Medicaid rate increase for 10 years. So if you think about that in and of itself, there's another sort of important point to think about, in that thankfully, thanks to the advocacy efforts of Greater New York, other organizations, and the leadership at OMH and OASIS, there have been rate increases in Medicaid starting last year for these two kinds of services, for inpatient psychiatric services and for outpatient mental health clinics. But I think, as you'll see here, is that our services are not just inpatient psych and mental health clinics. There is a tremendous array of different types of services because of the types of interventions and the types of treatment that are needed for all different kinds of behavioral health conditions. And in some ways, if we're focusing so heavily on inpatient psychiatry, which is very important, part of the issue with that is that when people are so sick that they need inpatient level of care, that basically means that someone has tried to commit suicide, someone has had a severe overdose and survived, someone has had severe symptoms and are unable to function. Our investments should focus not just on when things are that bad, but all the things that we can do and all the services that we can provide to help prevent those things from occurring. Why would we wait to try to prevent someone from trying to hurt themselves, right? The other thing to note is, and I know this topic is we're focusing on Medicaid, but one of the sort of unique issues for behavioral health is that we are underpaid by all payers, okay? We are underpaid by Medicare, and even in the commercial arena, we are underpaid. And I'm referencing a particular study here that was done in 2018, but it analyzed millions and millions of commercial insurance claims across the country, across all 50 states, where they specifically looked at if there was a differential in reimbursement by commercial plans in aggregate between psychiatrists and non-psychiatrists, namely primary care physicians. And they looked at specific claims and specific visit types. And what they found was that there was up to a 20% difference between the median reimbursement for a primary care physician, they got up to 20% more, versus a psychiatrist for the exact same visit type. So for the exact same, type of what we bill out as a CPT code by physicians, the exact same thing would be underpaid as much as 20%. They didn't have, they didn't go into exact reasons for that. I can have my own thoughts for that, but that's just to highlight that it's not just a Medicaid issue. And so for us, there isn't much in the way that commercial plans can help subsidize the underpayment of Medicaid, because we're underpaid across the board. And I think Dr. Michener and as well as Dr. Glowski also pointed this out, but particularly for behavioral health services, we've long been talking about access issues. We now have this critical workforce issue. We also should be talking more about the quality of care that's provided. And ultimately, how do we make sure that the people that we're taking care of are actually getting better, right? And there's all kinds of different things that are put in both monetarily and other ways to try to address workforce and access issues. But in my mind, it's until we address the underpayment issue, all these other things are just not going to be solved, right? If you can't keep the lights on, if you can't fill your vacancies, you can't provide greater access, you can't ensure better quality of care. So we really need to get to some of the core issues here, not to say we shouldn't focus on other things besides the Medicaid rates or underpayments, but that's to me is a real driving issue. So essentially, if we're saying we truly, value behavioral health, right, then we have to pay for it fairly. And by fairly, that's what I'm going to sort of go into a little bit. What exactly do I mean by fairly? And so what you'll see is I've sort of sprinkled in here various quotes in various, outlets or whatever where I or others have talked about this, because it's just not talked about a whole lot. I hope that this spurs on further discussion after this. But to go to some of the points that I was talking about. So I think it's important to talk about, so why is there such a big disparity for reimbursement for behavioral health services? And I think there's lots of different reasons, but I've grouped them into sort of what I think are some of the three big things. And I think we as behavioral health providers, I think people sometimes think, well, there's stigma. That's true. There's, psychiatry is special, right? Well, we're certainly different, but I think we have to be better able to articulate why exactly it's different and justify that to explain where potential solutions can come for better reimbursement. So I'm actually going to start with this bottom, the bottom circle, which was that, behavioral health is not one illness. I think, partly for convenience, but maybe for other reasons as well. When we talk about, quote, behavioral health, and even I do it sometimes, we sort of group it into this catch-all sort of thing, right? We have to remember that behavioral health conditions are comprised of hundreds of diagnoses. The 6 groups here, these represent just a handful of the major diagnostic categories, the major groups of illnesses that fall under behavioral health conditions. And under each group, I've listed just 2 of the many, many different types of diagnoses. And my point here is that the way that you treat, the kinds of treatments, the kinds of interventions, the prognosis for these different kinds of illnesses they're very different. The prognosis for someone with generalized anxiety disorder is very different than someone who's got PTSD, and the treatments are different, very different for people with schizophrenias. And many people have multiple diagnoses, right? So if we're talking about solutions to behavioral health for payments and the healthcare system for behavioral health, part of what we have to recognize is that it's not a one size fits all. We're not going to have a one size fits all solution because there's many different types of conditions. The other group I want to highlight is that there are some behavioral health conditions that are literally carved out from the quote from quote mental health care at the federal level. It's not just at the state Medicaid level. So what I mean by that is that if you have a primary diagnosis of a substance use disorder, and you have to have a primary diagnosis of some kind, a substance use disorder, a neurocognitive disorder, namely dementias, or if you have certain developmental disorders, namely autism spectrum disorders, you cannot be seen in a mental health clinic. That does not qualify for an inpatient psychiatric hospitalization. You cannot have that as a primary diagnosis. And it's like, well, why is that, right? Well, I think, there are in part because they're very different illnesses which require different interventions. But you can see even within behavioral health, there's these fractures, right? And it makes it harder and harder to figure out, well, how can we pay for this fairly when there's so many different types of conditions and so many different illnesses and prognoses. And then and there's already these splits here. So I think it's important to recognize that there's a multitude of conditions, but that part of the solution is that we need to not get sort of lost in the sort of the sort of murkiness of this all, and start to get really precise and target sort of our analyses and our thinking about the costs of taking care of some of these different conditions. So now I'm going to step back and talk about not sort of diagnoses or conditions, but sort of let's talk a little bit about sort of like levels of care. So this is a little simplified, but if we talk about general physical healthcare services, these are, I think, generally the main types of services that we primarily think about for if you've got a physical condition, right? So I don't think any of this is unfamiliar to. So, and even this can be hard to navigate at times, right? But that's not that bad because in my mind, that is in comparison to this. So if this gives you a headache, that's the point, right? What this represents is in New York, sort of not all, but some of the different types of behavioral health services and programs. And it's kind of loosely organized according to different levels of care versus different types of programs. And what you can gather here, I'm not going to obviously go through each of these, but first of all, there's a split between mental health services and substance use services, right? Even with an inpatient, you see up there, there's different types of inpatient services, right? In the outpatient world, which is what you start to see after the crisis services, starting with partial hospitalization, all that, there are so many different types of outpatient services. We don't have like primary care and specialty care. We're specialty care, right? But within our specialty care, we have tremendous sub specialties, right? And then when we think about it, and I'm so glad that Lamont is here, there are many different types. I'm not doing justice to the recovery-based programs. Those are so critical for certain conditions. Those are a part of that. And all of these, I think the point is they're all paid differently. They all have different criteria for eligibility. They're all paid differently. And if we think again about the access issues, and I think Dr. Michener pointed this out about we have robust benefits. We have wonderful benefits in New York for Medicaid and for people with behavioral health conditions. But to think about this, and if you think, well, where do I go? Right? If I have X, where do I go here? And sometimes it's confusing even for providers to figure out, behavioral health providers, where to go. So that's part of the access. And part of the issue is that both there's clinically different treatments and they're paid all differently. It's a vicious cycle. It's sort of reinforcing this sort of behemoth of different types of programs. And so if we're going to talk again, sort of at a high level about solutions, so what if, let's say, for the sake of trying to sort of make sense of this, and I think there is work already being done in this arena, what about if we start to think about all of these services and start to get towards a little bit more the way that physical health is organized in terms of, let's think about what's inpatient, emergency crisis outreach, intensive outpatient, traditional, all these things. There will be many different types of sub-programs. But I think part of our challenge is that when we say we want higher rates, is there's so many different types of programs, right? It's very difficult to figure out the costs in the quote outpatient setting because there's so many different types of outpatient programs. And I think for us to get traction in this is that we have to start sort of thinking about these sort of clear sort of categories, identify subcategories so that we can start to do this analysis better. And for some may have heard that Mount Sinai is building this brand new, huge comprehensive behavioral health center downtown. And that's exactly the model that we have. And the reason why we have this model is not so that we can figure out costs, is because we believe that these are the major sort of groups of services that are necessary. And that, we need to make sure that that's really a continuum of care that's available, but that's more straightforward and easier to navigate in any case. So that's sort of, sorry for the headache, but I think that hopefully that gives you some sense of that the access issues and the payment issues for behavioral health is in part, related to this. The second sort of big bucket or this big circle that I had was, the basic assumptions and the methodologies of how the U.S. pays for healthcare. So putting aside value-based payment, and I know there's a lot of focus in that, and there's a lot of promise and good stuff in VBP, but still, the vast majority of the healthcare payment system is fundamentally based on, it's largely physician-driven, right? It is largely based on, you see a provider, the provider does something, They often need additional information in the form of labs, imaging. They push a button, they put an order, someone else does something, they get the results, and then the provider makes a decision, right? And they continue to move forward. The difference here is that in psychiatry, and this is where I'm sort of getting more granular into why psychiatry is different, is much of the work rests on a single provider. We have, I like to say that our version of lab values or our version of imaging, so how we can make a diagnosis or how we can track progress or lack of progress in someone's illness, is there exists actually standardized diagnostic and assessment scales for all kinds of different conditions. The key difference is that unlike a lab value where you write an order and someone else does the lab and someone else and they get paid for it, the provider has to do that, right? We already do in many ways, as because of the nature of some of our illnesses, that we already have been, I like to say, we've been doing care management and case management. The average psychiatrist, psychologist, social worker who sees people, particularly with more severe, more complex behavioral health conditions, have been assessing and managing social determinants of health forever. Because for us, when someone has a behavioral health condition or symptoms, it affects their whole spheres of life. And part of the treatment is how can we get people back into functioning? How can we it's not only symptom mitigation or relief, it's how can we get them functional again, basically, or if they haven't been, how can we get them there, right? And so a lot of the kind of treatments and interventions for that, it's not just a medication, right? And it isn't just psychotherapy. There's all kinds of different interventions that are available. There's peer counselor services, there's occupational therapy interventions, recreational therapy. These are things that don't fit into our existing healthcare payment system. And so we don't have more hours in the day to do any of this, right? And so where do we get the resources and the time to do all this? And if you're already underpaid for the work that you do, and where do you get the money to find other people or other resources to help organize and help get people into these into care? And when community-based organizations do a lot of the sort of recovery-based work, if they're relying primarily on Medicaid or like grants and philanthropy, that's not sustainable, right? And so those are just sort of small examples of how, the nature of the illness, the interventions and the treatments that we have don't fit well into our payment system. And I think that's something over time, there have been ways to address that. And if there's time, I can go into that. But we need to, I think, be more assertive about thinking about, how these types of, interventions can be adequately paid for. The last piece that I talk about in its costs is there are lots of hidden costs in behavioral health care. And I think people have heard a lot about, behavioral health services are very heavily regulated. And I want to talk a little bit about, so what does that actually mean, as a consequence of being heavily regulated? This represents a snapshot federally, state, and other sort of agencies, regulatory agencies or rules or other national accreditation or certification bodies of the major types of sets of regulations that behavioral health providers have to follow. Okay, so not every, if you're a behavioral health provider, you don't have to follow every single one of these. But just to give an example, if you are a hospital-based opioid treatment program provider, like we are, we have to follow certainly the OASIS regulations. We have to follow the Joint Commission regulations. There are specific behavioral health accreditation standards for OTPs in the Joint Commission. We also have to follow, because we are hospital-based, the hospital standards for the Joint Commission. We have to follow the Article 28 hospital standards, right? We have to follow which was in line with the CMS on general conditions of participation for hospitals. We have to follow the DEA regulations. We have to follow the addictions privacy rules. We have to follow SAMHSA. So, again, it kind of gives you a headache, like, oh my goodness, how can you keep track and how can you follow and understand all of these regulations? And sort of where different ways it sort of starts to affect these behavioral health providers is that, as an example, for the clinician, the documentation burden is enormous because the documentation has to support and follow the regulations. There is a reason why our documentation is so long, right? But in order for people to document, there needs to be templates in the EMR, right? The behavioral health staff can't build the EMR. You need the hospital support, or the CBO needs, IT or robust IT platform to create these custom templates, right? All that takes resources. Who is going to actually manage and monitor that we're following and adhering to all of these regulations, right? Who's going to do the audits? Who's going to do performance improvement plans? Who's going to follow them, right? So again, if you're under-resourced, if you're underpaid, how do you manage all of this? And I think this is trying to get granular and sort of why the regulations for behavioral health. And I'm the regulatory person for behavioral health at Sinai. I completely agree with in terms of the spirit and the need for regulations. But I think we're past a tipping point where this has become an extraordinary amount. It just adds to the sort of and amplifies the underpayment issue and the not able to meet costs. There are many other hidden costs. I think, the one thing I just want to highlight is the revenue cycle and finance piece. As I've noted, they're all different types of programs. They're all paid differently. Even inpatient psychiatric services are paid differently. They're paid per diem by Medicare and Medicaid, and they are under what's called the MSDRGs. And the MSDRGs, what's very interesting is that there is one major DRG, which is called psychoses, but it's not what you think. The psychoses represent all the schizophrenias, mood disorders, including bipolar disorders and depressive disorders. Those are not all the same, right? And so there's all kinds of different nuances, and the cost to care for different conditions, like I've said before, is very different. On the outpatient side and the ambulatory side, all those different programs, they have different billing requirements, different codes, different setups that are necessary. And to be able to follow that, all of that expertise, the regulatory expertise, the clinical regulatory expertise, rev cycle, physical play, all that, even in a hospital setting, and we're very fortunate at Sinai because we have such a great collaboration and partnership with all our other departments, supporting departments, the expertise has to come from behavioral health, right? And we have to understand it and interpret it and make sure it happens, right? That again is another sort of resource. It's time and cost and people. And again, it's sort of, I think, emphasizes that it's not just the fact that, we don't have enough clinical providers. There's a host of other things that are required to operate behavioral health programs. And when we're underpaid, it makes it that much harder. So the key last thoughts and ideas, because I know I've thrown out a whole lot of different things. And I think this has already been said, but I will say it again, I will say it explicitly. When we are underpaying, particularly behavioral health services, that perpetuates disparities and inequities, right? This is, and I know that there's been so much discussion and conversation about how to address health inequities and disparities. And I know it's easy to say, right? And there's lots of different funding opportunities and lots of different ways that people are looking at to address it. Wouldn't it be if we increase Medicaid rates? And I know this is so simple, but I'm just going to say it anyway. That would go such a long way, right? That would go such a long way, considering what Dr. Michener presented about the overrepresentation of people of color in the Medicaid population. And if we can get to make sure that our services are more stable and that we're not struggling, then we can work on the workforce issues. We can work on the access issues. We can work on ways to figure out how to better outreach and connect and engage people of all different backgrounds, cultures, ethnicities, basically. If we don't have that pressure of just keeping the lights on, it would make this so much easier. And it's not going to be easy, but it would help pave the way in a different way. And I think if we start with that concept, as opposed to that's not possible, it's a different way of approaching a problem, right? The last two are really, again, there's a lot of great stuff in the governor's budget, and OMH and OASIS have been working tirelessly, as well as Greater New York and other organizations, to find all different ways to fund behavioral health services. And there are short-term things, but I think this is the time to look at long-term sustainability and put in solutions that are not just going to sort of fix immediate crises, like fixing immediate gaps in services, but making sure that existing programs can continue, particularly clinics. Those other services that I taught, that was on that sort of grid of services, those are often very highly specialized. If we think about the way I sort of think about the backbone of the ambulatory structure for behavioral health services, it's those clinics. They can serve the greatest variety and the largest numbers of people. And I think we really need to think about how we can sustain and help clinics not just survive, but thrive, right? And there are some things being done federally, and those are promising, but not every program can become the sort of certified community behavioral health centers that's growing at the clinic level. And the last point is, the key thing is, one of the key things we need to think about is not just setting up these services, but how we connect all of these services, how we functionally collaborate with the different providers, so that the person who's trying to access these services doesn't have to spend so much time trying to figure out where to go. We should take part, and we should own how to create, points of access, and that requires collaboration, and that requires more resources. So, David, I'm going to stop there because I've gone on and on. So thank you all.
No, thank you so much, Dr. Lim. That was extremely informative, and you really taught us a lot today. I just wanted to ask you a couple questions. One, it was very welcome that the governor focused so much on mental health services, both in her State of the State address and then also in the budget as well, right, and promised $1 billion over a multi-year period of time. And so, I don't want to be critical because we've not had that kind of focus in a very long period of time. It does strike me, though, that a lot of what's funded are new psych emergency rooms or new comprehensive behavioral health clinics, as opposed to, again, making sure we're investing what we already have. And as you mentioned, your programs are very underfunded, and, thank goodness we have a lot of hospitals who are willing to cross-subsidize you, basically, in your department. But is that how you view it as well, in terms of what's been proposed?
Right. So, and I agree with you. That budget is sort of monumental, right? And so, yes, there is. And that's exactly what I mean. There are certain gaps, and I do believe wholeheartedly that we need more CPAP. So that's wonderful. I think it's sort of having balanced investments in not only these new sort of filling the gaps, but also, part of the issue is that there's a drain on the mental health workforce and the behavioral health workforce, and there are many different competitors. And so, for example, a lot of mental health professionals, a lot of clinicians are moving to online telehealth companies, right? We can't compete with that. It's very hard for us to compete with that. And so what are the incentives for people to stay working in the community? These online health companies, they don't take Medicaid, they don't take Medicare, right? I don't want to disparage those companies, but they don't serve that population. So the community-based providers, the hospitals, the safety net hospitals, we are going to be taking care more and more of the Medicaid population, and the people who are the most vulnerable. And so we're going to need more intensive services. So, and if I think about sort of the kind of work that's needed just to make sure that we can, so that clinics aren't waiting lists, that people can access it, I think it's equally important to fund those sort of the backbone, what I call the backbone of the mental health care system. And so that we can do as much of what we can in a clinic setting as possible. And when there's a specialized need, just like in the physical health, right? When there's a very specialized need, we can refer out to certain other special types of programs, basically.
Right.
So, yeah, I think it's about really balancing and really not forgetting the existing programs.
Absolutely. Well, thank you so much for your presentation today. We really appreciate it. And it's such an important topic, and one that we again, want to try and resolve in this budget to the extent that we can. So now we're going to have a conversation. We're really excited about this conversation with Lamont Williams, who, as I mentioned, is a certified peer specialist. He worked his way up from entry-level peer counselor to now being a program manager at the New York City Health and Hospital Peer Academy. Mr. Williams, I was hoping maybe first for our audience, if you could explain what a certified peer specialist is.
Yes.
What you do.
Good morning, guys. Yeah, a certified peer specialist is someone with lived experience who gets their certification from the Office of Mental Health, I believe.
Right.
Yeah, so you have to have lived experience and go through the process of being in recovery and so forth and so on.
Great.
Yes.
So tell us a little bit about your lived experience and your history with utilization of Medicaid and how you feel it has changed over time.
Of course. Yes, I utilize Medicaid. It helped me in my recovery. I wouldn't be here today if it wasn't for Medicaid. But it has changed, right? It has changed from now as opposed to when I was coming in, when I was utilizing it. Like just for example, like when I was in like detox or rehab or something like that, we used to get like menus, right? We used to get treated with respect and dignity. I think all of that has gone by the wayside, right? You know, not being treated with respect, the stigma and stuff like that. And after you get discharged, you are given a ride home courtesy of Medicaid. Now you just either get a ticket, a bus ticket or something, and you just out the hospital. Even in inpatient now, the food that comes up is cold, which agitates people, patients that's on a unit, and it makes them act out. And then there's a cold called, and some people might get hurt in that, you know, de-escalation situation. So there's a lot of changes that is made because of the lack of funding from Medicaid,
Right.
and it's disheartening to see.
So you've seen over time that with the erosion of Medicaid funding, you know, it used to be many, many years ago that Medicaid actually had much better reimbursement rates in New York State than they have now. And you wouldn't have seen New York as like at the low end, the way it was described earlier of states in terms of reimbursement. But it sounds like you've seen changes because of this Medicaid underfunding.
Yes, yes, I have seen many changes. Even in the wait times and the emergency rooms. For example, there's a study from IT Services, right? Center for Medicaid and Medicaid Services, New York State, and New York State is ranked 5th with the longest ER wait times, with the patients waiting an average of 148 minutes. That is discouraging. That will make a patient get up and leave, right? And not even attend to the services that they really need.
Right. Absolutely. And you feel like you've talked to us a little bit about the shortage of inpatient state beds leading to overcrowding in inpatient units and longer wait times also in emergency departments. Do you want to talk a little bit more about that?
Sure. For example, I have a good rapport with a patient, and I was just in the hospital like 2 weeks ago, and this patient is back, and he's been there 4 months, and he's waiting for a bed for the state. 4 months waiting for a bed for a state hospital. That is ludicrous. That's outrageous.
Yeah, so, and it really speaks to some of what Dr. Lim was talking about the continuum of care. There's a place for state, right? And there's a place for regular hospitals, and there's a for outpatient, freestanding mental health clinics, as Dr. Lim was talking about. That's what you're talking about, right? The need to have all of those different options.
Yes, there should be options. But you know, COVID destroyed all of that. Another patient that I had, he was on his father's insurance. He turned 27. They kicked him off the insurance. He gets on Medicaid. He already has a provider. The provider drops him because he has Medicaid and he don't take Medicaid. So that
Right.
person came back to the hospital with no other recourse but to go back to the hospital because he can't get back on his father's insurance. And
Right.
it's discouraging for people who work for them. I work for people in recovery. And that's very
Right.
discouraging to me and of course to them.
Sure. Because they can't be seen in the right place at the right time necessarily. And one of the biggest Medicaid underfunding issues has to do with physician rates. And physicians, as we know, don't have to take Medicaid the way
Exactly.
hospitals do and the way, other providers do. So, so that's a really discouraging example that you've given and that you've seen.
Yes.
You've also said that Medicaid should consider funding essential needs for underserved patients when they're discharged. What do you mean by that?
For example, clothing. When the person's been discharged, most of the time we are serving underserved people that's probably living on the street, homeless,
Mhm.
and they come in, to get services, and then they are discharged. They don't get no, clothing. Right before was able to get clothing pre-COVID, you was able to get clothing. I remember going to Manhattan to get clothes and coats for the winter and shoes and stuff like that. I used to bring my own clothing to the hospital so my peers can be taken care of when they are discharged. And that is another cut from Medicaid, I believe, that is essential, that people need that to further them in their recovery process.
Right. Right, absolutely. There's so much emphasis these days on the homeless, either mentally ill or homeless people who have substance abuse disorders and sort of doing something about it. But it sounds like, the social determinants of health that Dr. Lim was talking about before have to do with just what you mentioned. I mean, something as simple as providing clothing, but also housing,
Yes.
also supportive housing. I'm sure that's what you see with clients when they're discharged.
Yeah,
For-
the supportive housing is a big thing, especially when they get back to that supportive housing, when they get discharged. They might have an issue with someone working on that in that supportive housing, right? And they basically set them up to bring them back into the hospital. And then now they don't have that connection no more, so they have to wait 3 months to get into another supportive housing place.
right,
So it
right,
it's disrupts the continuity of their care.
right. It's the kind of thing that Medicaid hasn't traditionally helped pay for, which is housing or food or other types of things that people need when they're discharged from the hospital. And it's hard to know how we'll solve some of the problems that we want to solve, particularly with homeless people, without those types of interventions as well, and really looking at those social determinants of health. And you also mentioned you wanted to speak a little bit about the peer department hospital-wide. What did you mean by that?
For one, I know that for a fact that peer counselors are needed in the hospital system because they are the bridges to the patient and the doctor. They tell more information to the peer counselor than the doctor.
Sure.
Right? So we can even help them with that continuity of care by disclosing some of the information that they are telling us, right, to the doctor, because they're not going to tell them.
Right.
And we have a better rapport. Just like if someone is in treatment for substance use, a lot of times they want someone who experienced that treatment, right? Not someone who's teaching it from a book. Not to say that people that book smart don't provide good treatment, but they want that experience with someone who's been there before.
Absolutely.
That's why it's important that, peer counselors be inside all the hospitals in
Right.
New York State.
There's a
In the
level of
nation,
trust
period.
there. Right. There's a level of trust there that isn't
Exactly.
necessarily seen elsewhere. And your services are covered by Medicaid, I believe. Is that correct?
My service. Oh, you're talking about the program?
Yes.
I don't
Yes.
know. No, it's not.
Oh, okay. I thought maybe the hospital for providing peer counseling services got something from the Medicaid program, but maybe I'm wrong about that.
Uh, um,
Hi, Dave. I'm just gonna, hi,
yes,
it's
please.
Rita Anders. I'm Director of Peer Services at Health and Hospitals.
Oh, yes.
So-
I'm sorry.
No, that's okay. It's a little gnarly. So when you refer to the program, Lamont is of course thinking of the Peer Academy program, which is funded by Health and Hospitals and the Department of Health and Mental Hygiene directly. But peer services are just reaching reimbursability, if I can make up that word, in substance use outpatient clinics, or what used to be called Article 32. And we've just opened in November 23rd of 2022. Article 31 mental health clinics, peer, individual and group peer support are reimbursable by Medicaid. But the problem, as I think we've heard throughout this presentation, is that the reimbursement rate is, I would call it trivial. And the work of a peer is reimbursable only when providing services. If it's traveling into the community, that is not reimbursable. Supervision is not reimbursable. So it's quite an uphill battle for peer support services.
Got it. Got it. So that's another one of those holes in the system that really needs to be looked at and filled. And what we keep hearing, and Geeta, I'm sure you understand this, we keep hearing, and Mr. Williams mentioned it as well, this whole need for looking at like the whole continuum and making sure that we really are funding that whole continuum from state psych, inpatient, outpatient clinics, and peers seem to be just so important to this whole system, because as Mr. Williams said, they're the people that are most trusted and can really speak to the physicians about, you know, what they're hearing and what perhaps the patient's not willing to say to someone else. So very, very important. Very, very important. Well, thank you so much, Mr. Williams. Thank you so much for your dedication to your profession. Really appreciate it. It sounds like from what I've heard about you and the way you do your job, you bring a passion to it, and a passion to clients. It's why you now are a program manager, as opposed to being an entry-level peer counselor. So really kudos and thank you for doing the work that you're doing. So important.
Thank you. And thank you all for having me on here.
Absolutely. And thanks for participating today. And thank you as well, Ms. Enders.
Thank you.
So that concludes our presentation. Ralph, can I turn it back to you?
Thank you, David. And I want to say thank you to all our panelists today. Thank you for joining us. Really incredible program. I also want to again thank our sponsors for sponsoring this webinar, Closing the Medicaid Coverage Gap. The Healthcare Education Project, 1199 SEIU, United Healthcare Workers East, and the Greater New York Hospital Association. I hope you'll all join us for our next program. Again, I'm Ralph Ortega, Editor-in-Chief at City and State. Thanks for coming.
Thank you very much.